Aloha, welcome to Healthcare in Hawaii. I'm your host, Josh Greene, Senator from the Big Island, ER physician, work with the Hawaii IPA. Today I'm excited to have a program with two healthcare experts from our state, George Greene, who's the CEO of HAH, as you see on your screen, which is the Healthcare Association of Hawaii, and Paul Young, another policy expert. Paul's title is Senior Director of Reimbursement and Public Policy, was at HMSA as a policy analyst before his job at HAH as well. These are the go-to guys in our state to talk about hospitals, reimbursement, and how all the federal rules affect our healthcare system. I find them to be terrific people and engaging experts. So gentlemen, thanks for joining me.
Thanks for having us.
You bet.
Great to be here.
It's great. Why don't we start off with you, George? Tell us a little bit of about what the Healthcare Association is for our viewers so they get a good feel for it.
Sure. Well, again, thanks for having us here today, Senator. The Healthcare Association of Hawaii represents all of the hospitals across the state of Hawaii. We also represent all of the nursing facilities across the state of Hawaii. We also represent home health, hospice, durable medical equipment providers, and assisted living facilities. In fact, we are one of only two associations in the entire country that represents that continuum of care.
Right.
In most states, the associations are siloed. One association for the hospitals, one association for the nursing facilities, on across that continuum. Mm-hmm. And with the implementation of the Affordable Care Act, we feel that we are in a really unique and advantageous position because, as you know, one of the tenets of the Affordable Care Act is for all of the providers across that continuum of care to work together for the benefit of patients. And in other states, associations haven't had lines of communication open to discuss how they're going to handle that patient across the continuum of care. Here in Hawaii, providers work together to do just that, to make healthcare better for the patients across the state.
I can tell you it's a great relief to not just have you as good people on the job, but to have that scope of responsibility makes it easier. I can only imagine how difficult it is for legislators like myself to try to find the right expert and then navigate their own niche and what conflicts might arise within the system. Whereas going to you, I know I can get an expert opinion quite quickly and really kind of, you see the big picture,
right?
Which is terrific. So that probably brings us then to you, Paul. Your role at HAH is as a policy expert. Tell me kind of a little bit about how you fit into the HAH.
Well, a lot of it, when George hired me, first time, it really looks at what the impact of the ACA is on reimbursements for our members.
Sure.
In particular, you're looking at, it's really Medicare, right, which is our public insurance program for the elderly.
Right.
And we're looking at Medicaid, which in Hawaii is called Quest.
Yes.
And that's really for our pregnant women, children of moderate means, as well as individuals.
Right. Yeah, so you guys as a team are also backed up by a pretty solid group too. What else does the HAH, what else makes up the HAH before we dive into some of these issues? Because I'm so interested in hearing your opinion and giving our viewers your opinion of how all these federal and state programs impact just a straight ability to deliver care. Who else do you guys have on the team? What other kind of groups?
So I was hired as CEO now a little over 6 years ago, and that was right around the time of the passage of the Affordable Care Act.
Right.
And one of the first things that I did when I came on board was take our organization, our members, through a strategic planning process. Mm-hmm. And we do have limited resources. We have a total team of about 17 members. But really, when you look at other associations across the country, we're very small in size at the Healthcare Association of Hawaii. We're very efficient. But again, we wanted to really get some feedback from our members as to how we should focus those limited resources. Mm-hmm. And so through that strategic planning process, there were several issues that were brought to the forefront. Number one, our members view us as an advocacy organization, representing them at the state capitol and in Washington, D.C. Underneath that umbrella, they also want us to play a role when it comes to public relations. So we have a public relations team in place within the organization. And they also handle education. So being an island state, when there are updates on federal regulations, new laws, historically hospitals, nursing facilities, they would end up sending teams of their employees to the mainland, which would become very expensive for them in order to get them updated and trained on the newest laws and regulations. So one of the roles that the association plays is we will aggregate the members and their employees, and we will go out to educational organizations. An example of that is the Joint Commission on Accreditation, which accredits hospitals who are following quality metrics across the country, just to give them sort of a seal of approval, stamp of approval. And I'm happy to say that all of our hospitals are accredited by the Joint Commission. And so rather than having hospital compliance teams, quality teams go to the mainland, we will work with organizations such as the Joint Commission to bring teams of educators here and bring all of our members together so that over a 1-day, 2-day, 3-day period, they can receive updates and training. With regard to public relations, really it's about getting the good word out about all of the things that our hospitals, nursing facilities, home health, hospice members are doing, whether it is making sure that they have the most advanced technology, whether they're making sure they have the appropriate workforce, whether they're doing work in the community free of charge or for low charge to try and help improve people's health. We really want to get the word out there about those opportunities and the great things that our members are doing. One of the other areas that our members asked us to focus in on, as you can see with Paul here today, is reimbursement. You know, we have one of the lowest Medicare and Medicaid reimbursement rates in the entire country. And so when you look at Hawaii, we have historically been a low volume, low utilization state, and we believe, our members believe, that we have saved the federal government a ton of money by being low volume and low utilization. So they asked us to work with not only the state, but the feds to try and improve those Medicare and Medicaid reimbursement rates. One of the other areas that we work in and focus in is on quality. One of the mandates of the Affordable Care Act is that no longer will reimbursement be solely tied to volume. You know, it's not, okay, the more services that you prescribe, you know, prescriptions, referrals, your reimbursement's gonna be higher. The tenet is you need to have quality outcomes, actually improving the care for patients. And so one of the things that we did is we went out and we hired a quality director and someone to assist that quality director in looking at all of the regulations that have come out from CMS and to work with our members to position them, educate them, and share best practices as to how they can meet those quality mandates and really exceed what those quality mandates require. The last area I'll mention is our emergency preparedness program. We receive a federal grant on an annual basis to work with healthcare providers to make sure that in the event of a hurricane, we're in hurricane season, in the event of a natural disaster, a man-made disaster, that healthcare providers and their patients and their employees know the actions that they should take to make sure that they can keep their services open and to make sure that they're taking care of those patients. And so we have a team in place that is actually not housed in our advocacy offices that works specifically on a constant and continual basis with a coalition of healthcare providers across the state to educate them about best practices when it comes to emergency preparedness and disaster management. They house caches of supplies across the state. They can actually stand up hospitals across the state when necessary if there's an overflow and there's a lack of capacity in the event of an emergency or natural disaster. So,
and I'm glad you mentioned that, George, because I had forgotten earlier to mention that when we were speaking, but you guys were incredibly helpful when we had last year the Ebola crisis, particularly, of course, in Western Africa. But as we started to see the occasional patient come to the mainland who had to be quarantined, though we didn't ultimately have any cases of Ebola in the state of Hawaii, we still had several scares. And your capacity to, as professionals, stand up education, to bring people together, to do training for all of the hospitals was invaluable. I mean, it was so extraordinary. It was Toby. We should give him a clear shout out. Toby was just terrific because he, by kind of coordinating all of the resources that you've got, was able to help us through what otherwise was a very serious challenge for the Department of Health alone. They were also terrific. Of course, their infectious disease division with Sarah Park and others were right on it. But that kind of partnership that came together with a little bit of work with my committee, but all the expertise from you guys and DOH, really meant that people felt safer. We got a lot of information out. And had we had an outbreak, we knew that the Healthcare Association of Hawaii would be right out there. You were even running emergency tests, right, and kind of drills out at one of the bases with the military.
Yes, we were. So one of the things that you mentioned, and you hit the nail on the head, is the fact that this is a partnership. We work very closely with the Department of Health and the city of Honolulu and the different counties with regard to sharing best practices and handling the education for disaster management and emergency preparedness. But we're constantly running what Toby and his team would call drills across the state, where we actually do trainings, and it is real time with volunteers who actually go through all of the process of what would actually happen if we had a case of Ebola, what would happen if we had a plane crash at one of our airports or a hurricane hit. And it is a full-on drill, all hands on deck, so that if something were to occur, every party to providing care in that situation has gone through the actual process so that they know what they should do. The idea being that it becomes kind of part and parcel to their knowledge, so it's not something that they're doing for the first time when and if something were to occur.
And you guys are on top of it because you also, if I'm not mistaken, run a full needs assessment. Why don't I turn to you, Paul? I know that that's, just so many things that the Healthcare Association does that people might not be aware of, but as its policy champion, tell us a little bit about that. How does that part of what the HAH does, the statewide needs assessment, factor into all these things that George is mentioning?
Yeah, so another one of the mandates of the ACA is a community health needs assessment, which must be performed every 3 years for private nonprofit hospitals. All of our hospitals, if they're not government run, are essentially private nonprofits. And as an association that represents all of them, it's great because we actually are, again, one of only 2 states that actually have a statewide community health needs assessment. It really, it's not just hospital specific, it actually involves community stakeholders, Department of Health, and some other entities to really kind of collaborate in trying to really bubble up and kind of percolate and trying to figure out what are the top 2 or 3 kind of statewide, right?
Yeah, it was really interesting last year when, or I don't know, maybe it was 2 years ago now, when you first did that full assessment.
It's actually 3.
3 years
It's been
ago.
3 years already. It's incredible.
Time
Amazing.
flies.
It blows my mind, I'll tell you. So, I mean, I would tell people this: if you're out there and there's only one document you're going to read about the, the state of healthcare in Hawaii, what HAH produces is probably the best document to kind of dig into, because it's so comprehensive in its scope and nature that you can read that and you can really see where our biggest challenges are, what our biggest health epidemics, if you will, are, where we fall short and where we're strong, and whether you're coming in because you'd like to provide services or you're wondering how can your organization help, it's right there in the HAH policy guide. Before we go to our first break in a minute or two, why don't you just lay out what are some of the biggest challenges that we've had in the state of Hawaii based on that needs assessment?
Well, based on the needs assessment, it was behavioral health the first time around.
Yeah.
Really looking at what are the issues surrounding that. You're looking at what are the community solutions potentially, and of course, how can hospitals essentially help that? Outside of the community health needs assessment, really, it's payment from public programs is our biggest challenge. I guess as an example, it's sort of like if a bento costs $10, public programs don't pay $10. So how do you stay open as a business?
Medicaid pays $6 and Medicare maybe pays $8, but it's still not enough for that bento half the time.
Yeah.
And you can't negotiate that, right? So Medicaid says we're going to pay $6, Medicare says we're going to pay $7, even though your cost for that bento is $10, and you can't negotiate it. You have to make up that shortfall off of commercial business or people who have the ability to pay privately right out of their pocket.
Yeah, fascinating stuff. And before we go to break, I'll just mention, really interesting you said that, because my last guests on the show were Mr. May and Dr. Bill Sheehan, talking to us about the Hawaii State Hospital just 2 weeks ago, and they were waxing philosophic about how the work that you guys did definitely demonstrated that that's one of the biggest challenges in the state. Of course, the Hawaii State Hospital has its challenges they're overflowing with patients at all times. They're probably under-reimbursed, and they have all these challenges because society hasn't yet been able to take care of the multitude of mental health issues that are out there.
Yeah.
But having you guys at our back telling us what priorities exist is hugely helpful. So Thank you again for joining me, gentlemen. Why don't we take our break, and when we come back for our next 15 segment, we'll dig into some of these problems. I'm Josh Greene with Healthcare in Hawaii, today joined by George Greene, Paul Young, executives at the Healthcare Association of Hawaii. Thanks for joining us.
Here's the deal. I'm Jay Fidel. I'm the host of Hawaii, the State of Clean Energy, which is the Energy Policy Forum's program on Wednesday. That's how we call Wednesday Energy Wednesday. We call it Energy Wednesday every Wednesday. Are you surprised? Okay, and we try to get guys like Jim Alberts here from Hawaiian Electric who can tell us what's really going on in energy. We want to be informed. It's so important. It's the most important initiative in our state. Clean energy is major, okay? And that's why we cover it on this show. That's the deal. What do you think, Sharon?
I think that's great. That's why we're here every Wednesday from 4 to 5, and we hope you all join us so we can hear people like Jim coming on our show and co-host Ray Starley from Hawaii Energy.
Okay, Jim, you've been here today. You've seen this. You heard what she said. What do you think?
I think it's a tremendous opportunity for people to come together and talk about the issues. Oftentimes, there isn't a good forum to bring these key issues out into the public, and this is a tremendous way to go about it. And the activity of this show is essential to keep talking about energy because, as you said, it's such an essential part of our lives that we need to pay attention to it and we need to think about the future.
Okay, Ray, your turn.
Well, this is a special time in the history of Hawaii where we're making some pretty radical changes in the way we use energy and generate energy. And this show is the one place you can count on coming to every Wednesday and hearing something about the latest issues that are on the table, being discussed, that will affect us all going forward. So come join us, and if you have some ideas you want to share with us about energy, give us a call and let us know. We'll put you up here and let you talk for an hour. So come see us.
Thanks, Ray. Thanks, Sharon. Thanks, Jim. It's great to be, from ThinkTech's point of view, it's great to have this show. We love the show. It's our most important show. So come around and listen to us 4 to 5 on Wednesday. Thanks a lot. Bye.
Aloha.
Aloha.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Greene, Senator from the Big Island, work in the ER and work with the Hawaii IPA as its medical director. Today I'm enjoying myself as the host with two excellent guests. We have two senior executives at the Healthcare Association of Hawaii with us, George Greene, who's our CEO at HAH, and Paul Young, who essentially is their policy expert. These gentlemen help us to understand the nuances of federal policy and how it impacts healthcare in our state, but they have a huge responsibility. As George described earlier, they're responsible for the breadth of healthcare services, not just at the hospitals, but also at long-term care facilities. They deal with durable medical goods. They deal with really a continuum of care in our state. And without their expertise, many hospitals would be jeopardized, from my opinion. I should mention that we have 28 private and public hospitals in our state, as many as 46 long-term care facilities, and they depend on these experts for information, for advocacy, and really to help the legislature and the federal government do a better job providing resources. But those resources are never enough, as we've seen. We have seen hospitals closed over the past few years. We saw HMC West close and then reopen under the, ownership or partnership with Queens. We've seen Queens move on to the Big Island and take into, under their wing, North Hawaii Community Hospital. We're also seeing consolidation of the hospital system on Maui, where HHSC Maui Memorial looks to find a partner in the coming months or years, provided that it passes legal muster. And if that happens, we will see consolidation of the hospital system, but those hospitals will still be there. But meanwhile, reimbursements are low. These are our experts. George, Paul, talk to us about why health economics are so challenging in Hawaii. You guys are experts on Medicare and Medicaid. Have at it.
Well, I'll go kind of big picture, and Paul can kind of fill in with some of the specifics. You know, here in Hawaii, we're the most rapidly aging state in the entire country. So we have a high Medicare population. And as I mentioned earlier, we have one of the lowest Medicare reimbursements from CMS in the entire country. So it really puts the infrastructure of the healthcare system at risk when you are not covering costs via your Medicare and Medicaid reimbursement.
It's my understanding, and I'm so glad you pointed that out right out of the gate, that our average spend for a Medicare patient in the state of Hawaii is somewhere in the $6,000 to $7,000 range, whereas some states get as much as $15,000 per patient per year.
That's right.
Why is that?
So we've looked at this, you know, they say that there's 9 ways to skin a cat.
Yes.
And we've looked at this a multitude of ways. You know, we think that the formulas when they were developed by Congress in conjunction with CMS. And we have a small congressional delegation.
Yes.
And when you look at the power of our congressional delegation, you know, they are well respected, but in what they call a pay-go Congress, where if one state increases their reimbursement, another state is going to lose in their reimbursement. You're looking at a block of our congressional delegation as juxtaposed with a California, a New York, a Texas. Even if you look at places like Omaha or like Nebraska or Missouri,
Yes.
their congressional delegation is much larger. And so when we try and just say we're going to try and take, we get outvoted.
Yeah.
So part of the rationale for us is, as I mentioned earlier, we believe that historically we have saved the federal government a lot of money as a result of us being a low volume, low utilization state. What does that mean? It means that we don't prescribe as much. It means that we don't refer as much, that people don't utilize the healthcare system as much. People like to be at home and with their families here in Hawaii.
Right.
So when the healthcare reimbursement was based on volume or throughput, it hurt us. It kept that number lower. So again, we think that we may have some opportunities in looking at this new value-based system. But again, because we've already historically been doing well as juxtaposed with the rest of the country, we might not have as many opportunities to improve our reimbursement here. So we are working very closely with our congressional delegation. They're well educated, they're well informed. They are in conversation with CMS to really talk to them about some of the rationale as to why our Medicare reimbursement should be improved. Paul can talk a little bit more about some of the information that we've provided CMS and our congressional delegation with.
I'll tell you, it's interesting too, and then we'll come to Paul because I know he has a lot to say on this subject. I have theories about this. One thing though that's interesting is we've had, in many ways, the healthiest population. We're considered the healthiest state in the country, and in spite of an aging population, as you pointed out, and in spite of a very, very low spend for our senior population. As a physician myself, I will tell you a lot of people are smart to avoid extra tests, extra diagnoses, extra procedures, which they themselves, those procedures, carry with them risk. Once people start down the road of a lot of medications, they have complications. So it almost can be viewed as a window onto how we in the Western world practice medicine. In many ways, Hawaii may have had it right. We might have been a low intervention state, as evidenced in a successful way by very long life and in general, good health. We've talked, and we don't have to get into it on this show, there's incredible health disparities, which have had multiple guests come on to the show, Dr. Neil Palafox and others, talk about how the disparities are terrible, and our population of Hawaiian individuals has much higher morbidity and mortality and lower lifespan because of challenges with diabetes and so on. But in general, Hawaii has been healthier even though we've spent less. So now we go to the federal government, Paul, and we say, look, our hospitals need to stay open. They need help. What kind of argument do you make when you go to them with some of these things that George said about, here we are, guys, we're spending way less than Massachusetts. We've been doing it right for years. We've been sacrificing. How do you convince them?
Well, I think the first thing is if you look back and say that, Medicare as a program is 50 years. We're celebrating Medicare's 50th anniversary.
Wow.
The ACA is 5 years old, Medicare is 50, 1965. If you look at the fact that the formulas essentially haven't changed since then. So, but for Hawaii, what's happened over time, as everyone knows, is our economy, once statehood happened, really picked up in the 70s and 80s.
Sure.
So Hawaii became a much more expensive state all of a sudden. We went from agriculture to tourism and rapid development.
Right.
And as the costs have risen, the federal formulas really just don't take that into account.
Amazing.
So it's really Hawaii, and I would say even Alaska is kind of in the same situation because, we were the last 2 states to enter the union, and we're
Yes.
also non-contiguous states. So that's another thing that we also push with CMS, which is the Center for Medicare and Medicaid Services. They're based out in Washington, D.C., and to them, it's, they forget about the fact that there is this vast Pacific Ocean that separates us from the rest of the nation. And really the added shipping cost, the fact that we have higher utilities cost here, and the price of land makes it so expensive, right? The capital expenditure that you have to put into a facility and maintain it is massive.
Right, and meanwhile, all along, people still have diabetes, they still have heart ailments. Let me ask you this question, and I'd be interested in both of your opinions on this. On many occasions, when I've talked to the CMS folks or our delegation, I've said, guys, help us here because we provide a very meaningful additional benefit to the United States, to the mainland United States. We provide a geopolitical advantage with, the military who we have the utmost respect for and adore, and they live here, over 100,000 military members live here in Hawaii. They need our hospitals. They have AAA, of course, but they also need our public hospitals, as do their families. And the entire mainland needs Hawaii to be strong and solid economically and from a healthcare standpoint as a state. Can you not take that into consideration when we, like you said, are 6,000 miles away from the mainland, and we need to provide this essentially base of operations? Mm-hmm. Have they been able to convey that? Has anyone been able to convey that in a way that would encourage them or incline them to give us a bump in our reimbursement, even above this pay-go, as George described, to help us with just plain survival? I worry that we could see another circumstance like when we saw West close. Their payer mix was 70-30, 70% Medicare and Medicaid and 30% private, and essentially they were doomed to closing eventually. I would hate to ever see that happen to, God forbid, Queens or Straub or another hospital. I don't think it will for those watching the show at all, so no one should be worried. But those guys, they struggle. They do a lot of care for less than it even costs to provide it. Can we make that argument?
Well, I think that's one of an additional argument that we're making with CMS is the fact that because of our geographic isolation, we really don't have any alternatives. I mean, if you think about California, which is our really closest kind of point of entry to the continental U.S.,
right?
They've got choices. Within their market, within LA, you can probably find 20 or 30 hospitals, right, within an hour's drive.
Sure.
In Hawaii, an hour's drive gets you about 5 miles on the freeway here.
Yes.
But we've only got really 7 hospitals, in Metro Honolulu, right, that you can access.
And if you're on Maui, you've got one.
You've got one.
You've got one hospital, and if that hospital were to fail, it would have to be bailed out. There's really no question about it. I think people can say, oh, we have a threshold for how much we're willing to support the public hospital system, but in certain parts of the state, you can't let a hospital close. Otherwise, people would suffer greatly, and the cost would skyrocket because they'd be transferred over and over and over again to Queens Straub, Kaiser. So we make that case, and we make it year in, year out. It's just a matter of, just being persistent until CMS really recognizes. Because I thought our opportunity, I've been in the legislature now, I guess about 10, 11 years. I thought our opportunity might have been back when the Affordable Care Act was getting passed, whether it was a rider or a description about the true unique nature of both Hawaii and Alaska, that would have been the time. None of us were involved in a central way yet, and I don't cast any blame. We got our share of military money, of course. But could that have been a time?
It could have been, and I think that, so to give you an example, when I walked into this position, the first board meeting I had was in October of 2009. And I asked them about their position on health reform.
Yes.
And they really hadn't taken a position. They were in a let's wait and see mode.
Yes.
And so I think moving forward from that, we got engaged very quickly. We ramped up very quickly. And we actually were able to protect some of what is called DISH funding through the passage of the Affordable Care Act.
I remember that now.
And it was a good transition because it helped those hospitals that are, and really all of our hospitals are safety net hospitals taking care of those most at risk across our state.
Yes.
I would say that now, the good news is that our congressional delegation is dialed in.
Yeah.
We are consistently communicating with them, and they're asking us for examples of how are the lower reimbursement rates some of the rules and regulations that CMS is passing hurting patients across the state. And they are taking those stories, that data, those facts to CMS. I would say secondarily, for the first time in, I would say, decades, CMS is actually reaching out to the Healthcare Association and the provider community, and we are regularly having meetings through CMS's Region 9 office to communicate these issues with them, with the goal being of improving things. Paul actually sits in on those meetings on a regular basis.
See, I think it's excellent to have you there, Paul, and to have George at your back, because they don't just find out what Hawaii needs, they find out what a rural state needs. I mean, there are isolated pockets of healthcare providers all across the country. Now, one could argue they're not and can't be as isolated, unless I guess they're in rural Alaska, as we are. But there are places in Montana and Idaho and rural Utah and Nevada that they probably do only have one hospital, like a critical access hospital, and too few providers like myself in the field. And they're going to need to learn these lessons in order to keep hospitals open and keep patients getting care. Why don't we take our last break, and then when we come back, we're going to talk about some of the accomplishments of HAH and how you've helped solidify our healthcare system. I'm Josh Greene with Healthcare in Hawaii. I'm joined by executives from the Healthcare Association of Hawaii as we talk about how to strengthen our hospitals, getting a full update. Thanks for joining me.
Hi, I'm Donna Blanchard. I'm the host of Center Stage here on ThinkTech Hawaii. Center Stage airs every Wednesday at 2 o'clock, and of course you can check out our archives on YouTube or on ThinkTech Hawaii anytime you like. Why should you do that? Because this is an arts show that I believe is making a difference in lives. We talk with artists of various ilk. We talk with painters and writers, playwrights, novelists, poets, sculptors, dancers, you name it, directors, actors, of course. And we don't only talk about what people do, but we talk about how they do it. And my favorite part of the conversation, we talk about why they do it. And it's really common on this show to hear people say, wow, I didn't think about it that way. And it's very common to hear people afterwards who have seen the show say the same thing. And I hear all the time that people are inspired by the conversations that we have. So why don't you join us and be inspired too? That's Center Stage on Wednesdays at 2 o'clock. We'll see you Center Stage.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Greene from the Senate, ER doctor on Big Island and director at the Hawaii IPA. Today I'm joined by two healthcare experts in Hawaii from the Healthcare Association of Hawaii, HAH, George Greene, CEO, and Paul Young, Senior Policy Analyst for George's team. We've been talking about our hospital system and the challenges it faces in the state of Hawaii. We're very isolated. We've seen hospitals close. We have some of the lowest reimbursements in the country for Medicare and Medicaid, and we just wonder to ourselves sometimes how we're going to make it through the year without seeing another hospital close. But since George came aboard, some landmark legislation was passed at his behest, notably the Sustainability Acts of Hawaii. These acts, I'm going to let George describe, bring a very significant amount of money to our hospital systems, and in my opinion, have kept some of them open in the most dire times. So George, again, thank you for being here. Thank you, Paul. You guys are, as we said earlier, very central to health policy analysis in the state. You're the go-to guys to make sure hospitals are taken care of, the long-term care facilities are taken care of. But when you guys came aboard, you saw that there was something missing that other states were taking advantage of, and you brought it to my attention and we acted. Tell me a little bit about the Sustainability Act.
Sure, and I would be remiss if I didn't first of all say, Senator, thank you for your continual support of these sustainability programs. So these programs take advantage of a federal statute, right, which allows different types of healthcare providers to essentially assess themselves a tax. This tax is essentially based on, or the program is based on trying to recognize taking care of the Medicaid population. Right. As we mentioned earlier, Medicaid does not reimburse the cost of providing care to these patients. In our state, before we implemented this program for hospitals, hospitals were being reimbursed about 70% of cost. So that means if it cost $1,000 to fix a broken leg and it was a Medicaid patient, the hospital was only receiving $700.
And I should interject here, and Paul and I were talking about this before, we have a very big and robust Medicaid program. We have now in the state of Hawaii, because of the expansion that Paul pointed out to me, we have 365,000 individuals of our population of 1.4 million that are on Medicaid. So every time an individual on Quest, or down on their luck, or having some challenges economically, went to the hospital, as you put it, we were only getting paid maybe 70 cents on the dollar for the actual costs of the care. Okay, so how do we fix this? Because you came to me and people smarter than me at the state capitol, other chairs, and said, many states are doing this, guys. We're missing an opportunity.
Right, and so essentially the way the program works is hospitals are allowed to assess themselves a tax. The tax can go up to 6%. And those funds are then sent to the state, which are then sent to CMS, and they apply what is called a federal matching rate. Each state has a different federal matching rate. For us here in Hawaii, it's about a 2-to-1 match, a little bit better than 2-to-1. Well, I'm sorry, 1-to-1 match. I wish it was 2-to-1 match. It's 1-to-1 here in Hawaii, a little bit better than 1-to-1 now. And those funds flow back to the state, and then they're dispersed to the participating hospitals based on the amount of uncompensated care they're providing. Uncompensated care being the measure in between cost and then what they're being reimbursed from Medicaid.
Right.
So prior to this program being in place, we had hospitals who were considering shutting down services, some of them on neighbor islands. We had nursing facilities that were thinking about closing their doors, some of them on neighbor islands. And literally, the bill was passed through the hard work of the state legislature. Again, you were a huge leader in doing this, Senator Greene. Now Governor Ige was part of this process as well and very integrally involved in passing this legislation. And once the bill was passed, we had to go through an approval process with CMS, and that took some time. And hospitals and nursing facilities were literally waiting. They were calling Paul probably on a daily basis saying, when are we going to receive the check? When is this program going to be implemented? And when those checks came, it was lifeblood to certain facilities. I don't want to name those facilities, but it was lifeblood to them. And it allowed them to continue to reinvest in workforce, to reinvest in technology, in some cases to reinvest in the actual infrastructure of the facilities where they provide care. So after the program was implemented on the hospital side, we were able to bring that 70% of cost up to about 83% of cost. I mention that because it's important to note that hospitals and nursing facilities are still losing as a result of providing care to the Medicaid population.
Right.
We're closer to cost on the nursing facility side, but hospitals for sure are still losing as a result of providing that care, but it's better reimbursement. So, you know, it's a program that's been in existence for 4 years. It has benefited our nursing facilities and hospitals to a great extent. I'm going to turn it over to Paul here in a second, but it's important to note at this point that CMS is going to require us to make some changes to our hospital program. But we have been working with consultants for the past 4 years who have implemented these programs in over 30 states across the country. And Paul has been hard at work with our consultants, and we believe that even with the changes that CMS is going to require, we have developed models that are going to protect the foundation of what we've currently implemented, and then actually provide opportunities for us to have incentives to have increased reimbursement for people who are meeting certain quality metrics. So it's going to have an accountability component so that, yes, we're still going to recognize the uncompensated care that you're providing to the greatest extent possible, but for those facilities that are meeting and exceeding agreed upon quality metrics, you're going to have an opportunity for increased reimbursement via this program. And I guess the last thing I'd say before I turn it over to Paul is that we have an agreement with the state that the state receives 12% of the assessment. So in this new world, in this new model that we've developed, the state's going to receive even more. And those funds go to the Medicaid program so that they can bolster the services that are being provided to the Medicaid population.
Which is as much as, I think, $2 billion now in our budget.
Yes.
Including federal funds.
Yes, federal funds. So, Paul, tell me, how much money are we talking about in these programs?
Well, in the current fiscal year, which started July 1st, it's roughly $88 million for hospitals. I would say it's another close to $20 million for nursing facilities.
So when George says lifeblood, I mean, those kind of numbers, without that amount of resource, in your estimation, could we have lost facilities? Would we lose facilities if we didn't have a program like this?
losing facilities may be a little drastic, I think, in terms of service lines.
Yes.
Certainly, we had a couple of hospitals say they had specific lines where they would have to close. They took a hard look, much like how we see on, HHSC's unfortunate circumstance as well, a situation where they have to make the hard decision of how do we keep the ship afloat, and we may need to, shut down certain sections. I mean, and really in those situations, there's no winner. Right?
There's no winner at
Everyone's a
all.
loser.
Yeah, I can tell you, HHSC, where I work on weekends in the emergency department, it does provide a safety net in the rural areas, especially in the neighbor islands, but there are now programs that don't exist. To not have a psychiatric service at one hospital might very well mean that if I have a patient that's got acute psychosis or schizophrenia or a severe drug problem that's resulted in a mental illness, they may not have to be transferred over to Queens or Kaiser. And those transfers are very expensive. It's ironic because I think it costs even more to deliver care to the individuals that need it most when we lose services. So by having a program that you guys recommend, and really all credit goes to you guys, to have that program in place to preserve these lines of services, I think a lot of people, they read in the newspaper about what goes away. I don't think people often understand what's been preserved, protected, and even expanded upon, because a lot of those things go, unmentioned, or this is pretty wonkish stuff. I mean, it's very complicated. So what will come in the next year? Now we're talking about quality programs and resources. Will we be able to continue to bring down these federal dollars if we do a good job?
So one thing that I believe it's important to note is that although this program involves a tax that is assessed on hospitals and nursing facilities, there's no taxpayer money involved in this. The people of Hawaii are not taxed 1 cent for the benefit of these programs. And it doesn't cost the state a penny. This is totally funds that are coming from hospitals and nursing facilities. In
Yes.
fact, as I mentioned, there's a benefit that accrues to the state as a result of us participating in these programs. We believe that the programs that we have developed moving forward are going to be even better than the program that we've had in the past. We have rubbed up against what's called a cap in the amount of funding that we can draw down from the feds as a result of our 1115 waiver. You mentioned this is very wonkish, and I won't get into the weeds here, but we were limited we were limited in the amount that we could draw down because of that cap that was in place. In the new program, we won't be as limited to draw down those funds.
So basically what you're saying, and again, unbelievably, I always fail to mention how fast we go through this program. Better we do, the more resources we'll be able to bring in. But that brings us back to where we started, your expertise. I think we're going to need significant guidance on how to achieve those quality metrics, how to set up programs that actually deal with our most pressing needs and issues. In our closing moments, what are the most important things that you think we can do to face the challenges we got here in the state of Hawaii on our healthcare system? Let me have you
We
speak first,
need to
Bob.
work collaboratively with our state government as well as the federal government to help preserve services for our residents here in Hawaii.
Because these programs a lot of times are funded, obviously, by federal and state dollars. George, emerging problems, what's going to be the biggest crisis we face in the next 5 to 10 years?
I think, as I mentioned earlier, we are the most rapidly aging population in the country. And I think if we don't work very in a concerted manner with CMS, our congressional delegation, to make sure that we have not only the acute care services, maintaining the infrastructure for our hospitals, but the post-acute care and community-based services, we're going to be in trouble because we will have an aging population that wants to age at home, wants to age in a community-based setting and not in a hospital. And if we don't have those resources, we're going to have the biggest, percentage-wise, we're going to have the largest elderly population in the country with no place to go. So I think that's a huge issue that we're going to have to face.
Well, George is doing his part. He's got a newborn at home, so he's decreasing our average age of our population quite quickly, but that won't be enough to save us from the Affordable Care Act and its consequences. So we do have these experts to rely on our behalf as Affordable Care Act 2.0 emerges under the next president, whether that's Democrat or Republican, we'll be well represented. Thank you for joining Healthcare in Hawaii. I'm your host, Josh Greene, Senator and ER Doc. Today we talked and explored what the Healthcare Association does, which is extraordinary work to keep our hospitals open, our long-term care facilities open, and and in future months, we'll talk about some of these and other emerging healthcare challenges we'll face. Thanks for joining us.
Thanks for having us.
Okay.